So in order to see if we can get all the questions answered that were in the chat, we'll start with Troy. What do you predict will happen after the value-based contracting in pharmacy becomes the next step leading to the next thing? Troy.
I lost you there temporarily. Can I have you back with that question?
Yeah, I need to repeat it for you?
Yeah.
Sure. What do you predict will happen after the value-based contracting, et cetera, in pharmacy becomes the next step, leading to the next thing?
People will realize that craft beer tastes good. I think the folks in the driver's seat, if you have the same package coming at you every year as a self-funded employer, particularly if you're large, and you expect things to change, right? So you're getting offered Bud Light, Miller Lite every year, and now there's craft beer. And what happened with craft beer is it's been around for a really long time, right? But what was interesting about the craft beer marketplace was if you had craft beer in one town, one brewery, it did okay. But if you actually had more than one, they all did better. And it's a true economic phenomenon. And the reason for that is because in that marketplace, it was really key that you changed consumer expectations. It wasn't about, oh, that brewery that we go to every once in a while. It was, oh, I drink craft beer now because I have a different expectation about what it is. So I think once folks get a taste of what real value-based contracting looks like in the pharmacy space, and plans are starting to see this, and I think that survey I gave you is pretty indicative of it, right? I don't think 5 years ago, 70% of plans would have said, yeah, we'll take biometrics from the pharmacy. But once they start to see it happen and plans and purchasers start to think in terms of, yeah, I want to hold the pharmacy accountable for A1C, I think it will take off. I don't know where all the actors will land, but I think the philosophy and the way of thinking will take off pretty quickly.
Thank you.
Yeah, Candace, I would add to that, I think that's what pharmacists should be doing. And, I think pharmacists, like clients, let PBMs kind of do all the work for them. Pharmacies have kind of let PBMs manage how they do business. And I think that paradigm shift has to happen, because right now, in the way, I hate to say this as a pharmacist, when we look at pharmacies, it's a commodity because that's all we're getting. Until somebody provides something of greater value, no one wants to pay for it. So just because you cost more from a drug perspective, we're going to look at it as a commodity. And that's what's happened in the marketplace. Think of Amazon. Amazon's creating that opportunity to get your drugs. As the baby boomers, age and these younger kids come in, that's where they're going to get their drugs. So if that's what's happening, how does pharmacy change to provide something different? So that, yeah, maybe you get your drug somewhere else, but you got to come talk to this pharmacist because you're just getting it shipped and nobody's talking to you. So I think the pharmacies have to make that change. And if we don't, we're going to, it's going to change the marketplace completely as more of these Amazon type opportunities enter the market.
And again, the economics are changing and bifurcating, right? So specialty is kind of really narrow channel. It's either the PBM themselves or the health system, largely not necessarily actors in the community pharmacy space. So as that generic number goes up, 91, 92, 93, 94, 95% of all fills being 18, 17, 16% of the cost. And somebody comes to you and says, oh, we're going to cut pharmacy reimbursement by 10%. Okay, so basically you've whacked pharmacy and the opportunity to get outcomes, and you've saved yourself 1.7%, and arguably you're actually not doing that either. So I think those two things in combinations, pharmacies sort of saying, hey, we have to expect more of ourselves, which is happening because they're not making any money anymore. That's the greatest motivator to actually change, right? And then simultaneously with, wait a second, you're saying you're changing my pharmacy reimbursement. That doesn't really do anything for me. So why are you cutting them, right?
So Troy, do you have any specific examples of contracts with pharmacists based on achieving patient outcomes?
Yeah, there's a pretty well-known one within Pharmacy Quality Alliance circles. So there's one payer that's got A1Cs, getting the A1Cs, getting it below 9, gets you basically bonuses. We participate in that one. The ones I showed earlier were not fictitious. Those were real. So we have a substantial shared savings opportunity around asthma. The interesting thing about these contracts, that contract, I'm a PhD health economist that had probably 12 credits in econometrics. That contract is about 30 pages of baseline econometrics, and you know, that's one of the other things that's taken a while for the market to uptake. These are not uncomplicated contracts, but they're largely successful. These companies that I'm seeing do this are re-upping them and they're expanding them. Every contract that we had for 2020 performance year is expanding in 2021, even the one that we didn't perform on.
Just, you know, if any of the other, you know, attendees want to add questions to the chat, please feel free to do that. I'm going to shift to Ed and Amy. Can you guys elaborate on the direct manufacturer contracts that you spoke about? Oh, we can't hear you, Amy.
Sorry, I'm using my phone. We're putting in our contracts the ability for our clients to do direct manufacturer contracting. And so we've been working on some processes with the manufacturers to talk about how we might be able to do that. It's interesting, the PBMs really have the manufacturers held hostage in a way, certainly the largers do, because there are contracts with them that are making it more difficult for employers to directly contract. But we have employers who have full custom formularies. And so the difficulty there is you want to manage your formulary. Depends on the PBM you're working with, whether you have full line of sight to what the rebate is. So to determine lowest net cost, after you determine the clinicals, then we want to look at lowest net cost. And that's difficult to do if they're not sharing rebate information with you. So one, when we work with a PBM and we know a client wants full custom formulary, we have to have full transparency to the rebate dollars at the drug level. Outside of that, we want the opportunity to go directly to the manufacturer if that's an option that we want. And so we've done that in the retail space. We've been doing that for almost 15 years now. And so it may be time to go directly to the manufacturer. And so we've got a group of companies that we've kind of come together, and we're going to approach the manufacturers about trying to do direct manufacturer contracting.
So,
go ahead,
Mark.
At CureX, we just changed our rebate aggregator, and we're getting full transparency on exactly what we're getting from the manufacturers. And so we can work with employers to work with their formularies, especially hospital systems, to say, okay, if you want your formulary to be this is what your rebates are going to look like.
Yep.
And so we're very excited to be able to offer that opportunity to work with whoever, but hospital systems, and one is the first one that they want to control that. And so we can show them exactly what their rebates will look like. We can turn in their formula into our aggregator and says, what will this formula look like? So we're excited to be able to have some different options. Usually those customized things just aren't offered through a lot of PBMs, and we're excited to be able to customize that and throw it out there and say, as consultants, this is what it's going to look like. This is what A, B, and C rebate formulary is going to look like. And now this is your option. And I think that's what Amy talks about too, is as consultants, that's what we want to do. We want to offer them full transparency on options we have.
Yeah, and I think the ability to do direct manufacturer contracting is important, as we've seen in the marketplace the changes. So you see the big three starting to create those entities that they own, that now they're using them as a rebate aggregator. So right. where they used to direct contract, now they've created another entity that they will use as their own rebate aggregator. Nobody knows what that's going to look like from a dollar perspective. So that's a protectionary mechanism to hold some revenue streams back. And so it makes the whole thing very difficult. And so we just want that contractual latitude to be able to do things that we need to do directly if we can't get our partners to do it with us the way we want it.
Yep.
Yeah, all those rebate companies are located outside of the U.S., just by the way.
Troy, did you want to add?
Yeah, I was just going to offer the economist view if I could, so nerd out a little bit. Again, for somebody that's a markets person, the two things that destroy markets are subsidies and transparency. Now, there's good moral reasons for those sorts of things, but they degrade sort of market competition. And one of the things that I've seen out there that, you know, gets a little bit in my saddle as a trained health economist is, okay, here's what you're going to have a lot of folks, self-funded folks will have offerings that come in front of them that say, okay, it's going to cost this minus X in the rebates. But if you want to see what the rebates are and transparent, it's going to be this minus X plus Y. You're going to get less rebates if it's transparent, which on its face is a little bit odd, frankly, right? But again, you all are business people, right? Would you rather have a number that you can say, I can see the data and I trust it? Or would you have a number that you have no way whatsoever of validating, right? It's not knowing what the coffee is, right? You can't manage what you can't measure. And they're saying, well, if you can't measure it and can't manage it, you're better off. I don't know how many businesses buy into that crap, right?
Well, the PBM business,
Right.
except TrueRx.
Ed, and maybe this is for Amy. There was actually a couple of questions about kind of the copay assistance program, but the first one was, how are you managing coupon sign up at the time of first fill for a variable copay program?
Yeah, so it's done a little bit differently for specialty and non-specialty. And specialty, they've been doing longer for sure. And that's, you know, most specialty drugs have a prior auth. So that's managed during that process. You know, depending on the PBM, they know what the copay assistance amount is. And so that's where the copay is set at that point. They're signed up for copay assistance when they're having that conversation. So as we know, specialty, there's always that conversation with the patient. So you get them signed up for copay assistance, and then that is applied as a second, copay assistance is applied as a secondary claim by the pharmacy. And so it's about the PBM process. So with Archimedes, so Candace, as you know, they don't own a specialty pharmacy. So they're just the PBM. And so they're adjudicating that claim. So they have the ability to stop that claim and make sure all things related to copay assistance happen, and then allow that claim to process. So it's all about how the PBM sets up that processing of the actual claim. And then for specialty, you've sort of got that closed network of specialty pharmacies. Usually people don't allow, you know, just an open network on pharmacy, but sometimes they do on the specialty side. You know, it is easier if you have a smaller network of pharmacies. So most of the time when we're doing copay assistance, we're doing it with just a couple of specialty pharmacies. So we generally have a much smaller network. And then the expectation in those contracts, because pretty much with Archimedes, everywhere we've done specialty carve out, we also have a direct contract for cost plus pricing on specialty. And so part of that contract contractually requires that pharmacy to participate in this with us and make sure that the patients are taken care of.
Okay. We're going to move to Daniel, give him a chance to answer a question. Daniel, what's the typical turnaround time for results once the genomic test is submitted to TrueRx?
Yeah, we typically say 2 weeks from when the patient places that sample in their mailbox. Often we see that more 10 to 14 day range. And I did see a follow-up to that regarding, do I ever see that being a shorter turnaround time? And you know, potentially one day there, you know, frankly, 2 weeks is pretty good when it comes to pharmacogenomic service, because most, and the context of the question had a little bit to do with inpatient care. We are focused a lot on those outpatient medications, but I can see where inpatient care could have the need for a more urgent turnaround time to select like the best blood thinner, for example. The holdup there is going to be most hospitals do not have anywhere near the capability to process those laboratory results on in-house. And so in a send away lab, as genomics currently is, 2 weeks is on the low end of a turnaround time. I have seen anywhere from 4 to 8.
Okay. And then there was another kind of question I believe was directed to you was, you know, why should an employer have to do this? Shouldn't the clinicians be using the technology within the larger systems to better manage the patient populations? Sorry.
Sure. You know, that makes sense. I appreciate Lori's comment earlier on that I looked younger, but looking back, it's been about 8 years since that class, if you can believe it. Even in that time when I was in pharmacy school, not too long ago, pharmacogenomics was still kind of on the verge of coming out and being starting to become a practical thing. And so it is a newer service. So when we look at many of our providers who, had their medical training prior to that, not all of them have the first line knowledge to initiate those tests. What we can do is help guide them with that and provide those results along with clinical recommendations, because we're pharmacists and that's what we do. Here's the patient, here's the problem, here's the solution. So should providers be ordering them? Perhaps. As the employer, though, a thought to consider is who's paying for that test? It's probably still going to be the employer. And when it's initiated by a provider and they're ordering a test that's billed through the medical benefit, that's likely to cost significantly more. I mentioned, the cost. What we're able to offer through our setup is about $200. It's $200 per lab test. I've come across several employers who have told me that they've paid $3,000, $6,000 for a single genomics test when it's run through as a medical claim. So whether the provider initiates it or not, the employer is still on the line for a financial portion.
I know I was asked a couple questions around the Remicade and that shift that we made. A lot of the savings had to do with the move to Inflectra, but a lot of it was site of care. And so a lot of those infusions were happening in the hospital, and we have moved it either to a community clinic setting or home even as well. So, and then in regards to that shift, have we had some feedback from providers? And the short answer is yes. Pretty vocal providers. Interestingly enough, when we looked at, we had a couple of providers in common. And so making that change to their patients, multiple patients, was, we got a lot of feedback. But, I think our key was talking with the employee and why we were making this shift and why we thought it was important. And then, of course, Archimedes took care of the clinical conversations with the provider. So eventually, I believe we moved everybody. So it worked out. But yeah, there is some rub and some back and forth with providers as they try to figure out what we're doing and why. So
I think also when we look at that, we look at SPD language we can put in to help make the statement that if you find a lesser provider that's high quality, that you can move that patient and that particular facility becomes the in-network facility. So there are some things you can do from an SPD language, find the same thing with this providers in network. And so we're working with our attorneys and risk attorneys to be able to put SPD language where it's not a question that particular facility becomes the inpatient, the in-network facility, because as everybody knows in the pharmacy world, the next golden egg is the infusion centers at the hospitals. They make, yeah.
It's my perspective that, you can negotiate, if you're using a TPA especially, you can negotiate directly with that outpatient hospital facility. We know they're higher cost, and that provider can do it in their office. The dynamic in the market is a lot of these systems are now, I don't want to say owned, but the physicians are employees of the system.
Right.
And so you can see and claim one day, same drug, same dose, administered in the doctor's office is $2,500. The day they became part of that entity, place of service changes, it went up 6 times. And so happy to negotiate just like we do with pharmacies or just like we do with a pharmacy MAC list. This is the price we'll give you. If you want to keep the member, we're happy to leave them there, but this is the price that we'll reimburse. So that's an option as well, if you can work with a TPA that's willing to help you with that direct negotiation on the medical side. And we have clients who do that.
Right.
So Sherry, somewhat on that same line, You mentioned that employee noise was relatively low, but have you had kind of that feedback from providers or, any?
No, we had a very smooth transition, but we give a lot of that credit to the pharmacy staff at the domestic pharmacy locations at Eskenazi. They're just phenomenal, and they really helped shepherd those members through. Had they not been taking care of their own employees, there may have been more noise. There may have been.
We'll go back to Mark or Daniel. Can you discuss the range of prices associated with your solution and what is the range in the general space?
Yeah, I mentioned the test itself is $200, which for a one-time test doesn't have to be repeated. It's not too bad. Everything else that goes with that, the pharmacist consultation, those recommendations, the ongoing monitoring, the secure portal for the results, that's included in a PEPM fee. First year is $3 PEPM, and after that first year, we have visual discussions about how that will taper down.
This one, anyone wants to chime in. Someone said, many of the programs that manage the copay, they don't work for the high deductible health plans. Can someone help clarify the timing of how these work? Is there any way to better manage the programs through the vendor? Sorry.
On the, I think Amy said it, on the specialty side, it's easy because they need prior authorization. And so we haven't applied the copays to the deductibles for a while. And sometimes they get the medication for free because they can't afford the $2,000. And so then we just get it off the plan immediately. So I think that on the specialty side, it's fairly easy to do to work with the members and to make sure that copay doesn't get to reaching their deductible. I'm not sure if I answered that or not. I kind of forgot the question, I'll be honest with you.
You're right. You went into
Amy can back me up. I got started and I'll just be honest with you.
Amy kind of hit on it, but I think you hit a little bit more details. So I think that was, that's fine. So another kind of statement and question, nowhere else in healthcare are kickbacks allowed. Why do you think that it's tolerated or legal in the pharmacy space? That's not directed at any particular person. So
the need for price discrimination. I mean, you can't charge different people in an open marketplace different prices. There's GLP costs that are $1,000 to some customers and 5 cents to Medicaid recipients. Right. And so it's an addiction. If I'm Medicaid and those dollars are going to my general fund and the Medicaid rebate program, I'm dependent on that. If I'm a plan and 20% of rebates are coming back to me and I need that for my under the MLR profit or things that I want to be able to do, I'm dependent on it. So we have a real Gordian knot right now. And, one of the things I would encourage you to do on the high deductible plan for instance, is see how many of your enrollees in high deductible plans ever actually even use their insurance for drugs that actually get a benefit from their prescription card. It's really low. And that should kind of tell us something about how kind of the system's a little bit messed up. And it begs the question, why are we even adjudicating 90% of drugs? Why are we even administering them? Right? It costs more to administer this whole system for 90% of drugs than if you just gave it away and you say, here's my gold card. If I'm holding the gold card, I get a free, here's what the standard price is. So again, to me, the power of the consumer is the thing to watch, because as high deductible plans, to some of the confusion that goes on, if you need an expensive product, then you're in a different world. But again, that's 2% of fills and even a fewer percent of patients, right? And so if 90+% of your patients never ever use their drug card, why do we have a drug card for them? That's not insurance.
I don't know if I agree with 100% of that, but I think it's how you manage the plan, though. So right. You can have a high deductible plan and you can put things in place that incent utilization of the right drugs at a low cost for the member. You can put preventive lists in place. We've got clients who do value-based benefit. We give the drug away for free. We want you on these drugs. If you have a condition, we want you on it. And even though you have a high deductible plan, we can still administer these and lower your cost.
But
So I don't know
yeah.
that I believe exactly what you said, but I think it's a lot around how you manage the plan.
But I think what you're saying, if I could put words in your mouth and tell me if I'm wrong, is, but wait, we want to be able to manage care, right? And so
we want to help the member,
right?
choose
Yeah,
correct, choose
sure,
efficiently.
that's fine, but that's not insurance, right? So my point is, it's become something different than insurance. Insurance is something that you pool risk for a rare, unexpected event. That's not hydrochlorothiazide and lisinopril, right? It's a inexpensive, not rare event. That's not insurance, that's something else. And so again, thinking creatively, you think the reason for administering it really has to do with how are we helping manage care? And that's really what I'm saying, right?
We have one last question, and then we'll turn it over to Gloria to close out. Mark or Daniel, are the tests you currently use only looking at medications that the FDA says the data could be used to support therapeutic recommendations?
Denise, that's a great question. There are a lot of theoretical drug-gene interactions that some of them I think will play out when the research comes, finally comes to fruition. Some of them will realize that didn't really mean anything clinically. So it's important that we're not making medication changes just because we found a theoretical abnormality that maybe there could be a medication issue. No, we're going back to Pharm GKB, the CPIC guidelines, to see what is actually recommended in those guidelines that has evidence behind them to say that in these situations, a medication change or even a dose adjustment is warranted. Now, the test itself is a test of about 20 different genes. And so as more research comes available, we might find that something that wasn't recommended to be actionable now, maybe later as the research develops, we'll get more clarity. But to your point, we're not making medication dose or change recommendations around theoreticals. We're going off of what the evidence shows. Great question.
Well, I personally thank all the panelists for, helping me navigate through my first virtual moderating session. So appreciate it. But we're going to turn it over to Gloria to kind of close us out.